It's really about not having everything in every place all the time, but having what a patient needs in a community that is accessible within the clinical model that fits for whatever particular service line they fall into.
Welcome to Rural Health Today, the next chapter of our preceding show, Rural Health Rising. I'm J.J. Hodshire, President and Chief Executive Officer of Hillsdale Hospital, and this is a podcast where we connect you, the listener, to what really matters the most in rural health. I'm thrilled to be in the studio with a very special guest, someone that I have had the pleasure of getting to know even better just today in learning about his life story and his background in healthcare. It is my pleasure to have Dr. Greg Johnson, Regional Market President at Parkview Health, in the studio today. It's your first time.
Yes, it is.
In the studio. Very exciting.
Yes, it is.
Now, some of your colleagues from Parkview have been in this room. David Wynn, Lori Schramm, the list goes on. But it's great to have you in the studio because you bring a unique perspective to healthcare, both a physician as well as a senior leader. And I'm excited to talk to you about those challenges and opportunities that we face today and looking at healthcare, not only in rural communities, but across the country.
Yeah, and that excitement is shared, JJ.
Excellent. So let's start with the fun stuff, okay? Because we're going to get in some deep subjects here in just a minute. The fun stuff is to tell our listeners a little bit about yourself, because someone's listening from, Montana, has no clue who Dr. Johnson is. Give us a little bit of your background. Talk to us a little bit about, where you've been and what you're doing now at Parkview Health.
Yeah, so simply went to medical school in Missouri. I did all my postgraduate work at University of Wisconsin, both internal medicine and nephrology.
Cheese curds there, isn't there? Yeah, lovely.
So nephrology is kidney specialist and practiced, moved from Madison, Wisconsin. My wife and I moved to Fort Wayne, Indiana in 1994 and raised two children in Fort Wayne. I was in private practice for 15 years. And the opportunity arose to become chief medical officer at Parkview. And I look back and I think that was a good decision at this time.
Yeah.
At that time, it was a little apprehensive, but had the opportunity to serve as chief medical officer for 8 years. And then other various roles related to population health and value-based care. And then currently I serve as regional market president, which essentially is the hospitals across the system, those leaders report up through me.
So, Dr. Johnson, you made the leap, right, to what we call the suits, and you went from delivering care, but I know for a fact you were still delivering care.
Yeah.
While you were, let's not minimize that fact. So you were still practicing up until just a few years ago.
Yeah, so I did keep my hands in practice and would, it was not, when I'm with physicians, they look at me as an executive. Yeah. And when I'm with executives, they look at me as a physician. I will say my physician counterparts are much harder working. Yeah. When I was seeing patients a half day a week in clinic, they're working 24/7. And
sure.
So I don't like to put myself on the same level as my physician colleagues because they're out there serving every day.
Sure. So what was the biggest, so you made the transition. Talk to us about the challenge of going from providing care, at the bedside to now you're dealing with systematic approach to things, statistics and numbers and reimbursement. What was the big aha moment for you in that transition?
Well, I think the aha moment was how I made the decision, is that I felt that we needed more physicians and providers to be not to be the sole leader, but to be part of the leadership team as it relates. Right. And Mike Packnett and Rick Henby, our previous CEO and our current CEO, have really excelled physician leadership in looking to physicians to lead the health system. Again, not by themselves, but in conjunction with other executives.
Didn't know Mike as much as I know Rick. And when you think of the word servant leader, you think of Rick.
Yes.
And you think of the work that he does. And so, he's obviously surrounded himself with other, and having the opportunity to talk to you today, servant leaders, which I think is so important in our industry today because it's changing. It's ever changing. And I think your perspective from both physician and now as a leader can really shed some light into some of the challenges we're facing on both sides of the spectrum. How do we take care of the patient, ensure high quality? But on the other side, it's cost containment, right? We have to talk about all those things. And I think Parkview, I just want to give a plug for Parkview, has done a great job in the state of Indiana. Primarily, I know you have an Ohio base, but primarily Indiana, of really being the leaders. When I think of healthcare leadership, I think about Parkview and what you've been able to do, the give back to your community, the building of those rural communities. I think it's very important. And it's really what we want to talk about today is how does big health impact rural health? And I'm going to let you talk about that in just a minute. So let's first talk about relations. So you have a big health system and it's big. I mean, you have how many employees? Probably close to 10,000?
16,000
16,000 plus. So it's a little bit bigger than Hillsdale. So 16,000, bigger than the city, by the way, of Hillsdale. So you have 16,000, associates and members that are working for Parkview and working with Parkview. And so it's a health system, but you also collaborate with rural health too, because I think that's who you are as well. So why don't you talk to us a little bit about how that relationship works with Parkview in rural health? And I think you have a hand both in rural health as well as big health, but they all play a role, don't they?
Absolutely. It's an ecosystem. And so Parkview, we get rural real fast. I'm not the one that came up with that phrase, but we do get rural real fast.
Yeah.
We have 9 rural hospitals within our health system. We actually have 2 large hospitals in Allen County, Fort Wayne, Indiana, and a behavioral health hospital in Allen County. But we are very rural, but it doesn't stop there. Those relationships, when a hospital has joined the Parkview family in the past, it's generally been they're trying to fill a need, and it's not about Parkview filling a need. It's about Parkview helping these rural hospitals remain not just surviving, but helping them thrive.
Yeah.
But we also, and this is one of the things that I'm very proud of, is we want to support the independent rural hospitals. To manage hospitals in 2025, the infrastructure that's required, whether it's technology, whether it's particular processes, informatics, you could go on and on.
You could.
It becomes very expensive very fast, and we have to keep up with it.
We do,
because that's the quality that we want to bring to healthcare
and what patients expect.
Exactly. Right? Yes. And so I look at it as an ecosystem. If we have a rural hospital, whether it's part of the Parkview family or whether it's an independent hospital that we work with, it is best for patients to receive their care locally. Period.
I agree with that statement.
Period.
I think we could close in prayer right there.
There you go.
I agree.
But it's the truth. And,
it is.
And there's a couple reasons. One is that's where the patients want to be.
Access.
People don't necessarily want to make the trip to the big mothership. Likewise, the Parkview Regional Medical Center is really there for tertiary care. So if we can help hospitals, our own as well as independents, keep patients in their facilities, that benefits everybody involved.
It does.
Our emergency rooms are busy, and we want to make sure that our throughput is just as efficient as it can be, and helping rural hospitals with that efficiency helps us.
It sure does.
So it is an ecosystem.
It is. Great perspective. And so, it's not as if there are some big systems where they're knocking on the doors of rural hospitals saying it's not if, it's when we're going to take you. Your philosophy at Parkview is a lot different. In fact, a lot of the folks are knocking on your door. And that relationship's important because both parties then mutually understand we have a relationship. So, Dr. Johnson, I'm gonna hit some tough topics.
Sure.
Because when you go into rural communities, you may not be able to keep all of the rural services there. Talk to me about how it makes sense to take, let's just say, a rural community and let's divest a program that they're used to having for decades. And how do we wrap that up in a conversation with better outcomes or care?
Yeah, so it starts with the clinical model. So we are a service line organization. And the service lines, whether you're talking about cardiology, behavioral health, women's and children's, I could name them all.
Sure.
But what we're really around service lines. And those clinical models are the basis of where we begin. And so you have to have certain volumes to maintain clinical excellence. You have to have, obviously, certain providers. And as you know, providers are tougher and tougher to recruit nowadays, especially with new grads coming out of their fellowships. So it's really about not having everything in every place all the time, but having what a patient needs in a community that is accessible within the clinical model that fits for whatever particular service line they fall into.
Right. And having the bandwidth maybe is going to be at the larger institution than it would be necessarily duplicating that across 9 different hospitals. And you get synergies, and you also get opportunities to have even better care.
Yeah, because for example, if you could take any service line and say, well, we do 500 of these procedures a year. If you get dropped to a certain level where you're not doing a significant number of those procedures, one is you lose expertise. Quality could be affected. So we like to have these centers of excellence or areas of excellence. In some hospitals, some of our rural hospitals will excel in a particular service line.
Mm-hmm.
And yet down the road, another one of our community hospitals may have an area of excellence in a different specialty, but they play off of each other. And this is what and again, it's all evolution.
Mm-hmm.
What I'm proud of Parkview is that we're looking at it as not just looking at a community hospital, not just looking at Parkview Regional Medical Center,
Mm-hmm.
but looking at how this network, this clinically integrated network or delivery system we don't want to walk away from any patient in any service line. We want to make sure that they have the access that they need. And I think that's evident, and we have over 1,200 employed providers. If we weren't employing those providers, that access wouldn't be there.
Right. They may not even be in your area still.
Correct.
Because it's very difficult for, when you look at primary care or specialty care, in today's economy and trying to find employees, let alone the cost of malpractice insurance, for a lot of our folks to make it on their own. And so there has to be a relationship with someone, a hospital, and it can serve both ways, right? But at the end of the day, it's taking good care of our patients. In the other relationships that exist, for example, Parkview and Hillsdale's partnership is that we are on the Community Connect product, which is an EMR-based system for how we document records. Okay, Epic. So we're on Epic, and that is kind of that's like the Maserati, of EMRs that we could never afford. Okay, but because you have it, you can offer it under a Community Connect project, in which we can get it at a fraction of the cost with the relaxed start clause, and that's very helpful to hospitals like ours. Now, you're not telling us how to do business. You don't have access to that data. It's just you're being friends of healthcare, and that helps the healthcare system overall. I think that's a big work, and from my understanding is you don't just do it with Hillsdale, but you are offering it.
Yeah, I was going to say Hillsdale is special.
Well, thank you.
But I don't want you to feel too special.
I never do.
And that we do provide that service to many hospitals in Indiana.
Yeah. Let's talk a little bit about what's happening at Parkview, and specifically what you're doing in programs, because you're everywhere, man. Parkview, you sponsor events. You've got a stadium named after you down there. Lots of things are happening. You're giving back to your community, tens of millions of dollars. But you've got yourself, you must be excited about a few programs. Like Dr. Johnson is excited about Program X. What's exciting for you right now at Parkview, and what are you thinking, this is our next step in healthcare? Yeah,
so I think it's really designing the clinical programs that support all the various communities. And as I said, I'm going to probably say it again in this podcast, it's not walking away from a patient. Mm-hmm. When we talk about consolidating services and across the United States and things like that, sadly, there are times where health systems are actually walking away from patients because they can't make it work financially. Yeah. And so the thing that excites me is, how do we figure that out where we're not walking away from any patients?
That's right.
And providing, it'll be different.
Yeah, it has to be.
It has to be.
It has to be.
It'll be different, but really putting that patient first and use the term servant leadership. Mm-hmm. That's what excites me on a day-to-day basis, is getting up and being able to think about impacting not just one patient at a time. I love practicing medicine, but the fact that you can impact, hundreds, if not thousands, if not tens of thousands of patients.
So let's talk a little bit about that, because let's go into one service line that is a huge need in rural communities across the country, oncology services. You've recently dedicated a new center, a cancer center. Can you talk to us a little bit about that and how you serve the region for cancer?
Yeah, so the Family PACNet Cancer Institute at Parkview. I will say that the model, as a clinician, I was a little hesitant at first because I thought it was an awfully expensive model.
Yeah.
But what's really, and I was wrong, and I can't believe I'm saying this when it's being recorded.
I'm going to give this to your wife so she has record of that.
So So when I say I was wrong, I knew what we wanted to accomplish. I just didn't know how successful that would be without and control costs. But really, I'll start with this. One of the things that when I was chief medical officer, and we would have a woman come in and have a mammogram done, and that mammogram would be abnormal. So the woman's notified of that, and then she's gonna have certain follow-ups to come up with the diagnosis and plan.
Right.
Literally just a decade and a half ago, that would take 50 days, 50 days till the diagnosis and plan.
That's
were in
an
place.
eternity.
It is. And mentally, spiritually, it's a
physically.
Major burden on a woman. Because instead of taking the patient to all the various specialists in oncology, we put the patient in a room and bring all of the specialists to the patient. And we accomplish this now. I'm sure my Cancer Institute leaders are listening, but we're under 17 days.
Wow.
And
it's life-changing.
It is life-changing.
It is.
It is life-changing.
A day is an eternity waiting for results.
But here's how our model in the Cancer Institute really fits with rural health, is that, yes, if you're going to have and hopefully nobody has to go through this, but if you're or a loved one are having a major surgery for a cancer, you're probably going to come to Parkview Regional Medical Center to have that done. If you're going to have radiation therapy or chemotherapy as follow-up, you don't want to drive from 50 miles away, 30 miles away every day to come in and get that treatment.
Yeah.
So what we do is we have a distributed model, is that you get your diagnosis. If there's major things that can only be provided at a tertiary care center, they get provided there. But then we disseminate it back into their communities. So a lot of our community hospitals do the infusions. We also have our community hospitals. Some have radiation oncology and linear accelerators that can treat patients. So again, it's best for the patient. That's where it starts. Sure. But driving those patients back into their communities. And anytime you can make treatment, I'll say, easier or seamless, you end up with better outcomes.
You sure do.
You take that emotional and physical and mental stress off of patients while they're going through something that is very, very challenging.
Yeah, and access, of course, in rural communities is almost non-existent for that specialty care. When you think about nephrology and you think even about oncology and some of those ologies, rural communities cannot afford to have those programs. So having someone like Parkview that can have that outreach, is what I would call it, is life-changing. And I want to just congratulate you and your team for the work that you've done there in cancer, but also in so many other disciplines. I mean, you and I were talking earlier today about the work that you're doing in behavioral health. There's such a need in that in this country, but the work that you're doing is very, very noble. So I want to thank you for what you've done. Now I want to get into the hard stuff.
All right.
Okay, because that's easy stuff.
All right.
Hard stuff is what we're facing as an industry. I've done some reading.
Yeah.
I see that you're in a pretty rough state, my friend.
Yes.
The state of Indiana is pretty tough. You, as a state, have not had a rate increase in Medicaid in decades. You're delivering care that costs a lot more money than it did even 2 years ago, but let alone decades ago, trying to contain costs to the best that you can. Serving a population in rural communities typically is a 70%, Medicaid, Medicare is what we typically see. A lot of folks that are on Medicaid also, are trying to work. It's not that they're just being lazy, but they need access to care. Maybe they work for an employer that's 50 or less. There's a lot of reasons why people get Medicaid, right? And so at the end of the day, the issue that we're facing as a country right now is the recent news a few weeks ago out of Congress, which there's going to be substantial cuts to the Medicaid program. First and foremost, you're serving a Medicaid population, right?
Yes.
In Indiana. And a lot of your rural communities, I would assume, are going to be more Medicaid dependent.
I'd say 70% of our patients are either
Government
Medicare,
payers.
Medicaid, government payers.
So you're going to be similar to what the demographics are throughout the country.
Yes.
Higher incident rate in Medicaid and rural communities, but still proportionate to all your hospital centers. You're seeing those rural communities. It's going to be impacting your hospital as well. But Indiana, it's a tough state. You've got a lot of discussion about payments and a lot of discussion about, what are we going to do with hospital system X? But at the end of the day, all of that pales in comparison to what the federal government may do to us.
Yes.
And what do you do in advocacy, as a system? Who do you partner with? And what's concerning you about this legislation?
Yeah, so the thing that probably concerns me the most about the legislation is that they attempt to solve a very complex problem with simple solutions,
Yeah.
and the unintended consequences are what get us. So, and if I could elaborate on that just a bit, there's a lot of focus on prices.
Mm-hmm.
And I would be wrong if I said price doesn't play a role in the cost of care. What I think plays even a bigger role in the cost of care, though, is making sure that the patient's getting the care at the right place at the right time. And so often, so if you would allow me, we have a model at our Southwest campus on Illinois Road in Fort Wayne, that it's a freestanding emergency room. And it's a very novel model. We were not the first. We're probably the fifth or sixth in the country that have used this model. But when a patient presents to that emergency room, they're evaluated by a nurse practitioner, by a licensed nurse practitioner, and then they're triaged appropriately either into emergency room or urgent care.
Mm-hmm.
And now, if we just had a freestanding emergency room, they'd all come through, they'd get an emergency room care, and they'd get an emergency room bill, which is a lot
very
more,
heavy.
a lot more than urgent care.
Yes, it is.
And so, when I was in practice, we would have a patient come in the emergency room, and you're like, well, they really don't need to be here, but you treat them appropriately, you give them the best treatment possible, and they end up with an emergency room bill. With this model, we found in the first year that we were open that 50% of the patients were emergency room appropriate and 50% of patients needed urgent care. And people are, well, that's great. But the rest of the story is if I take the average cost of an emergency room bill that we have and an average cost of an urgent care bill, and then multiply by the number of people who actually went through the emergency room or urgent care, we saved the community $9.2 million in 1 year.
My goodness.
And that's our first year, where we're even busier in our second year.
Yeah,
so, and those are real dollars. So part of it is, so when you talk about, it's easy for a politician, I was going to pause when I say that, but it's easy for a politician or someone to say, well, healthcare is expensive.
Right.
And it is.
Or nomenclature like price transparency.
Yeah.
Or, right.
Yeah.
Right. And easy to say.
It
resonates with the people.
It does. The key, though, is that it's not just prices.
Correct.
It's really about creating models to get people to the right level of care. If you can deliver care in an ASC versus inpatient, an ASC is an ambulatory surgery center. Right. It costs less. If you're getting the same quality and safety outcomes, you should be doing it at the right site. And I will say, as an industry, if we would continue to spend more time on appropriate utilization across the health system, that to me would be more cost savings than any price reductions.
Absolutely.
One other example is when I was in private practice, nephrologists take care of hypertension, often difficult to control hypertensive patients. And I would manage a patient and I would see them back every 6 months. Now, did I need to see them back every 6 months? No, I probably could have. They probably could have faxed their numbers in. I'm showing my age a little bit there. Fax numbers in or send them in through Epic, my chart, and I could assess them and I could make adjustments. But the reason that I had them come into the office was that was the only way that I was reimbursed for taking care of that patient's problem. Right. Now, it inconvenienced the patient. It probably took a spot in my office that somebody else could have been using. But that's a micro example of where, because of the way payment systems are set up, this fee for service and volumes that we only get paid if we do something, that I think
incentivizes.
Actually it incentivizes, it drives up the cost of care, and it also decreases access.
You know what? I can see the headline right now. Johnson for Secretary of Health. Because I'm telling you, if we can fix that, this is all very easy. And but you're absolutely spot on. And the work that you're doing at Parkview is remarkable. We could talk about so much more, and we could talk about workforce readiness. We could talk about the talent pipeline. I want you back for that. But I want to give just a few minutes for you to really define and outline.
That's your way of telling me not be so verbose?
Well, we're going to get there, though. We're going to get there. I promise you. But it's an opportunity for you to share a little bit about, what's the future hold for Parkview? I mean, you're big. Is it sustaining what you have? Is it, entering some global initiatives? what would you see? And I know you can't necessarily say on behalf of so-and-so, but what do you see as the next chapter for Parkview?
Yeah, the biggest chapter is relationships with all hospitals, with all providers, with anybody that wants to partner. We want to be part of that equation, because I do think that the infrastructure cost, and I use that term globally, it's the second time I've used it in the podcast, but this infrastructure cost isn't going down.
It's not.
It is not going down.
Going up.
It's going up. And so how do we create some scale? And it doesn't have to be ownership or acquisitions.
Right.
It doesn't have to be. It can fit sometimes, and it may make sense.
It makes sense.
Right. But how do we create this scalability so we can share these kinds of resources? And the example you gave with Epic Community Connect is just one of many, but it is a very solid example.
But you have a laboratory and you have other services that we could, hospitals can link into, still maintain their own autonomy, but have access to specialty care, tertiary care, yet still maintain their independence in their rural communities.
And those are some of the traditional things. If you start talking about artificial intelligence,
let's talk about AI.
Business intelligence, clinical intelligence, risk stratification, that's an expensive endeavor.
It is.
And we need to have groups of providers together to share the cost across the...
Well, you can bring scale, right?
Yes.
Because at the end of the day, the biggest threat right now that we're experiencing outside of the political movement is really around what we would call this ransomware that's happening, where hospitals are paying out millions of dollars. And imagine this, a rural hospital, I just had a friend tell me, a rural hospital in another state far away who bankrupt their hospital.
Yeah.
They shut their systems down for days. They had very little cash on hand, and then they get charged with this ransom.
So JJ, let me throw something back at you then. What I find interesting when it comes to the ransomware is that the health systems that are being held ransom are often painted as the perpetrator.
Oh, I know.
And not the victim.
Preach it.
Yeah.
And you know what? It takes attorney generals to stop blaming us for this. It's the state sponsors of terror is who the ones are doing this.
Yes, sir.
And we need to go after them. And we're the bad guys, you know, and so we have to change that narrative. That's going to be for another podcast.
Yes.
But I'm passionate about that. It's one of the things I'm passionate about.
I figured I'd touch on that.
Yeah, absolutely. And I think that's important. But I think as we conclude today, the message is big health has a defined purpose that's very important, but it can incorporate rural health into it, which is what you've demonstrated at your hospital system. Not all hospital systems are the same. There's been hospital systems knocking on my door before that said, it's not if, it's when we're going to take you. And we're going to turn this into a helicopter pad, and your patients will have to go to place X. God is my witness, that was said. That other executives from big systems come in and call us Hillsborough Hospital. Would have the respect of knowing who we are before you say you want us. And so the relationship that Hillsdale has with you at Parkview is a prime example of how we can work together, maintain our independence and autonomy, but help each other out in this very turbulent time in healthcare. So thank you.
Very well said.
I appreciate what you've done for our hospital, for communities throughout Indiana. Now you're into Ohio, parts of Ohio. And it's just been great to be able to work and to watch what has happened and the growth that Parkview has been through. And with growth, there's a lot of pains, there's a lot of misunderstandings, there's a lot of community commentary, but I'm going to encourage you to stay the course. Y'all are doing a great job down there and impacting the lives of those who need it the most in communities like ours.
Thank you, JJ.
Well, thanks for joining us today on the episode of Rural Health. We would like to wrap it up with our new segment, Rural Health Recommendations. For every guest we have on the show, we'll ask them to contribute a recommendation on rural life and healthcare. Now, it could be a tip for someone now that's going to work in healthcare, is working in healthcare, some sage advice of thriving in a rural setting. And then we're going to add this recommendation on as an online guide to help others, who want to learn, what is that recommendation at ruralhealthtoday.com. So I'm going to ask you, Dr. Johnson, what is your rural health recommendation?
Embrace it.
Embrace it.
Period. And when I say embrace it, whether you're talking about recruiting providers, retention of providers, recruiting nurses, embrace it. The rural life is most of America, And I sometimes get a sense that even in our own community hospitals that are in the rural settings, that they often feel like, well, we're just rural. So it's not just rural.
No.
We are rural.
Yeah.
And I say embrace it. Recruit to your strengths.
Yeah.
Whether you're urban, suburban, or rural, there are strengths and,
There
opportunities
is.
across all of those.
Yes.
And it takes
Fishing versus shopping,
Yes.
right? I mean,
yes,
it takes all of it.
But it also takes good healthcare executives to not use, it's rural health as an excuse to be something that they should be.
Absolutely.
To not be something that they should be.
Right.
And so I just, number one, embrace it.
Love it.
Lots of opportunities.
I absolutely love it. That's going to be my new phraseology. Embrace it. So when we have folks that are saying, man, this is tough, embrace it.
Absolutely.
Or we don't have an advantage. Yes, we do. The advantage sits right here. Opportunity. So embrace it. Love it, Dr. Johnson.
Yes,
thank
sir.
you so much for joining us in the studio today. I look forward to having you back here in the future. And thank you to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural healthcare every Monday, wherever you get your podcast. Don't forget to check out the latest updates and resources from Rural Health Today at ruralhealthtoday.com. And make sure you've subscribed to the show so you can never, ever miss an episode. Until next time, choose to celebrate rural health and life. Choose rural every time. Remember the difference that rural health makes. Remember the power of rural.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.